Thank you, Dr. Vanathy. Good afternoon, everyone. Thank you for this opportunity to be a part of your course, Vanathy. It's always a pleasure. What I'm going to do is essentially introduce the techniques of keratoplasty, really. And for all of us who are in this hall and all of us who are trained as corneal surgeons, what do we train in? We essentially train in, what's happened to this mouse? This mouse is gone. Okay, better now. So earlier, when keratoplasty was originating in 1905, the anterior lamellar grafts were the norm till the importance of the endothelium was widely accepted. And it's only later, almost 70, 80 years later, that the understanding of replacing only the diseased tissue came back to the fore, and history essentially turned full circle to allow for anterior and posterior lamellar surgeries to be done. However, penetrating techniques still remain the gold standard in transplantation procedures, and essentially because this was the only technique that was considered effective and easy, all of us as corneal surgeons learned the PKP techniques during training. It's a relatively straightforward procedure. It has universal applicability for corneal transplantation, right from anterior stromal disease to the posterior or the endothelial dysfunction, essentially, which means that one technique fits all. And in any case, when you look at late stage presentations, whether it's Fuchs dystrophy or whether it's CHED or whether it's any dystrophy, essentially the whole cornea eventually gets involved. And if patients present late, then only a full thickness corneal replacement is the solution. These are some of the indications which are just available in standard text. And as you can see, almost any corneal pathology is amenable to a full thickness transplant. Of late, we have had so many advances in our experiences and in their operating microscopes and surgical instruments, the sutures, the availability of better corneas, and now, of course, the femtolasers to enable a better cut profile and flange. These have improved the outcomes a lot. So coming to the procedure itself, we should talk about the preoperative preparation, the use of preoperative antibiotics and steroids. This would again go across all forms of keratoplasty. Attempts to decrease the vascularization, IOP lowering agents, the peri and intraoperative preparation with the pupil and the intravenous mannitol or intravenous diamox, steroid and antibiotic injections at the end, and the kind of anesthesia. I personally prefer for my full thickness keratoplasties a general anesthetic, as I think many corneal surgeons would. It just gives you less stress while you're doing the surgery. But local anesthesia combined with lignocaine and bupivacaine also works well, provided you can achieve good akinesia. So this is just small little clips just to show how important it is to center these grafts. That's a barren punch that you have on the top to prepare the donor, which is what I would in conventional keratoplasties do before I do the recipient. And then at the bottom here is the use of the Baron Hesburgh trephine, which is again my favorite. It's a vacuum-based trephine. And after marking the cornea, one can go ahead and trephine. I often don't do the full thickness of the trephination because I don't like the gush of fluid, and I will leave the last bit to be done. As you all know, this trephine can also be used for lamellar surgeries. We know that one full rotation, which means 4 quadrants of full rotation of this trephine, will give you 250 microns of cut. So that's how the donor is prepared, and then it's covered with the viscoelastic and a little bit of the medium. So when we've done the astigmatism and we've done the trephination, we should look at the suturing and evaluate the kind of trephination that we've done. So one of the biggest reasons why we don't have good quality vision sometimes in our grafts, and that relates to lamellar grafts as well, is high post-operative astigmatism. And one of the major factors in this is the ovality in the cutting. And so ensuring that you have a round donor cut and a round recipient cut is extremely important. And we know that ovality produces significant amount of astigmatism. Of about even a 0.3 millimeter of ovality will produce more than 3 diopters of astigmatism on this account alone. The bevel is another issue wherein we have to ensure that we get a vertical cut on both the donor as well as the recipient. So the objectives of suturing are to obtain a perfectly aligned and watertight closure rapidly with very little override or posterior gape, and to minimize the tissue compression and unequal tension. And for that, one needs to prefer shorter and deeper bites. We must optimize the fit by increasing the sphericity, ensure the best apposition when the graft is placed in the recipient bed. Always try and grasp tissue radially with the anterior lip in your grip and not the full thickness. And the sutures should pass directly beneath the grasp point to reduce torque. Using slip knots and keeping them fairly tight in the cardinal sutures is extremely important, and one must maintain the depth of the anterior chamber as one works. So this is some of the principles that you'll see being highlighted here. You can see here that the tissue is resting on a bed of Healon, essentially, which is sitting in the anterior chamber. There's a Fleringer ring, if you notice, and that ensures that you have, in this patient who's had a vitrectomy, ensure that you don't have globe collapse and you will not produce a malapposition inadvertently, because even slight malappositions produce significant amount of astigmatism post-op. The use of the slip knot is being demonstrated here, wherein you can use a single throw and then come around and do your pulling in a north-south fashion. And I'll show you here how you titrate the slip knot. And as you can see, you'll notice, is there a pointer here? You'll notice a little bit of whitening just about there. See that whitening come up? That whitening is what tells you that you've got adequate tension in your knot. And that whitening tells you that there's good quality apposition. If you over tighten it, you'll have too much whitening and you can loosen it. And then you lock in the knot by doing some east-west throws, and you're done with the slip knot. And you can do the same thing all around and pretty much continue with the cardinal sutures. Oops, there's another little tip that I wanted to actually show you. I'll have to go back to the previous one. Do I have time, Vanity, or am I run out of time? I think I am running out of time. All right, so I'll just move on. Essentially, what I wanted to show was that one of the ways to find out the best position for the 6 o'clock point on the donor is to use the thread. And don't cut it when you've done the 12 o'clock suture, but use the thread to go and find the best point that you have at the 6 o'clock position, and it gives you the best possible apposition. Here, of course, one sees the final closure in this patient. We've done 8 cardinals, and we're going to put in a 16 bite continuous with it. And as you can see, the bites are all radial and are deep as far as possible. And at the end of the surgery, we have a very nice look to it. When we are finally closing these grafts, it's important to do 2 things. 1, deepen the chamber. Don't finally do the closure of the final knot without deepening the chamber. 2, release any bridal sutures, release this, the tension from the speculum, because that will help get you a much better closure without the chance of wound leak or excessive tightening. We also use a ring like this or a device like that to try and see if we can get some sort of circularity of the Myers. Any additional procedures, again, and that's where keratoplasty of a full thickness has value, is that when you have a very opaque cornea and you have to do the whole thing, you have to do open sky techniques, and this is an open sky rhexis being performed. We are also, the advantage of knowing the penetrating keratoplasty techniques is to do things like regrafts, and then you have very bad patients like these, wherein I'm not even refining, I'm just using the old regraft area to try and see if I can tease open the same little area and put a new graft in it. And you can see on the top that I'm completing the rhexis in an open sky method. And after that, I can just deliver the nucleus with the simple hydrodissection, do the IA, and let's see if I can fast forward this. This is my last slide, actually, Vanati. So that's the nucleus being delivered, and that's just the IA being done. Here on the lower side, you can see a vitrectomy being completed, and after that, the positioning of the graft, pupilloplasty. These are again only possible through full thickness techniques. It's very difficult to do these maneuvers if you've got a very small or a narrow opening. And DALK pretty much follows the principles of a full thickness keratoplasty, but all the endothelial keratoplasty techniques actually follow more cataract principles than corneal surgery principles. And so there's quite a bit of difference between the way the traditional corneal surgeon works and the DSEC surgeon. Thanks so much, Dr. Bhanati. Thank you so much for everyone for giving me a patient hearing. Thank you.
Thank you very much, Dr. Rishi. And Are there any questions for Dr. Rishi, any of the budding corneal surgeons here, or if you want anything which Dr. Rishi will be happy to clarify you as Dr. Sumati would set up her slides. Yes, please. Please come over to the mic.
Can we have the lights? No, it isn't, unless the patient is you're doing a fresh pseudophakia. If he's a round pupil pseudophakic from earlier who's stable, you can do a PK without doing a PI. If there is a vitreous possibility, do a PI.
Yeah. Dr. Rishi, tell us about Schweringer's ring, advantages and disadvantages, and how often you use it.
Good question. All my aphakics, I'll use it. I'll use it in all my pediatric cases. I'll use it in patients where I expect that I'll be spending a lot of time doing reconstructive work. People who've had traumas, I'll use those. So those are pretty much my indications for doing it. I don't see any real disadvantage other than the fact that it takes a little time. It just adds 5 or 7 minutes to your surgical procedure because you have to first put it in, then you have to take it out. And then you need a little bit of experience because it does interfere with some movements, especially when you're passing your sutures. Sizing is very important. If you have a fairly large size graft, ensure that you've got a 16 millimeter Fleringer ring. Otherwise, you'll have problems as you're passing your sutures. That's about the only tips really, but it's a fantastic tool. Any other questions?